Hello everyone, my name is Nudelman. I'm a PGY2 internal medicine resident at Memorial Healthcare System in Pembroke Pines, and today I'm presenting a case called Kikuchi Fujimoto disease in pregnancy. So KFD is known as histiocytic necrotizing lymphadenitis, and it's a rare but relatively benign condition characterized by cervical lymphadenopathy, night sweats, and fever, classically seen in Japanese and other Asian young women. However, there have been isolated cases in the US and Europe. Etiology is not well known. However, usually a preceding viral or autoimmune illness is seen. So on pathophysiology, infection, injury, and underlying autoimmune process leads to T-cell activation and apoptosis and cytokine storm. This severe process can actually precede development of malignancy and development of SLE in these patients. Non-invasive diagnostic tools are usually inadequate in these patients, and the standard of care is excisional lymph node biopsy to confirm. We present the case of a 29-year-old African-American female who came to the ED with exacerbated cervical lymphadenopathy and pleuritic chest pain. She had a past familial history of IDA and HSV type 2. Vitals were normal. Labs were only significant for leukopenia, bands at 6%, anemia at her baseline, elevated D-dimer 1.07, a positive pregnancy test, and negative blood and urine cultures. Physical exam was only significant for multiple tender lymph nodes along the posterior cervical chain bilaterally, as well as tenderness in the cervical musculature. CTP was followed up due to the elevated D-dimer, which showed no evidence of PE, but showed scattered sub-centimeter ground glass opacities in the lungs. Notably, she had visited the ED 2 weeks prior due to swollen lymph nodes and a sore throat and fatigue. She had some positive sick contacts at home, and she was just discharged with Augmentin and prednisone. However, on a subsequent outpatient follow-up, she tested positive for PPD and pregnancy. She came back to the ED due to worsened lymphadenopathy and new onset chest pain, as well as night sweats. So patient was admitted to the hospital. ID and OBGYN were consulted. ID did a full workup, which only returned positive for EBV IgG and inflammatory markers that were ESR 49 and LDH of 326. HEMONC was consulted to rule out any malignancy. Peripheral flow cytometry was normal, and then they asked for a lymph node biopsy, as you can see in figure 2 on the ultrasound. Throughout her week-long hospitalization, she actually improved. Her lymphadenopathy became better, and she had less pain. So she was discharged home with prenatal vitamins and instructions to follow up with a PCP for the biopsy results. 1 week after discharge, pathology results confirmed KFD, as you can see in figure 1, and oncology recommended no further treatment or workup unless she became symptomatic again. She ended up having an uncomplicated third birth, and she had no additional symptoms. So for discussion, how does KFD commonly present, and why is our patient unique? So KFD is usually unilateral. In our patient, she had bilateral lymphadenopathy, which is only in 20% of cases, and she also had a positive PPD test, which made diagnosing her a little more difficult because it brought in differential to TB infections or other possible malignancies. Classical findings on histopathology of KFD are absence of neutrophils and eosinophils, Kr-Rex of histiocytes, and formation of foamy histiocytes. Is KFD commonly seen in pregnancy? It is not. There have only been a few cases. Some of those cases were complicated by postpartum hemorrhage, miscarriage and development of SLE, prolonged 41-week gestation, and then failed steroid treatment. Your patient had a positive EBV IgG. Is there any association? So there are a few studies. The most significant one was done in 2000 in Taiwan. It took 10 people with KFD and checked to see if they had EBV expression on PCR, and it showed that all of them had expression, but it was variable. Finally, what considerations must be taken in pregnant patients when diagnosing and treating KFD? So the biopsy for diagnosis is safe. Most importantly, we should avoid NSAIDs in these patients after the procedure for pain control. Sometimes corticosteroids are used and patients have continued symptoms for long periods of time. However, they should be used sparingly in pregnant patients due to association with cleft lip and palate. And post-resolution, they should be monitored for development of SLE. So this case is important because it talks about this rare disease. It talks about its possible associations with EBV, management of this case in pregnancy, and it's crucial to do a full workup when you have a patient like this, but keep KFD as a possible differential in your mind.